Good morning. Hi. I am Garima Gupta. I am one of the GI and neuroendocrine medical oncologists at University of Alabama at Birmingham. It's a pleasure to be here with everybody and talk about neuroendocrine tumors. To give a little bit of background about myself, I just moved to Birmingham less than 2 years ago. I was at University of Kentucky where I trained with Dr. Lowell Anthony and Dr. Chauhan, who's also going to be giving us a talk today. And Dr. Rose is here as well. He's our surgical oncologist at University of Alabama. We recently did start a multidisciplinary neuroendocrine clinic. So we're here. We have a multidisciplinary team for neuroendocrine. Please, we'll be happy to take care of you, okay? All right, so my talk today is going to be just focusing on the basics, whether you are newly diagnosed, you've been living with this for a while, or you have a family member. Hopefully, some of the information that we're going to talk about today is going to be a little bit less, make it less overwhelming for you when you've been diagnosed with this disease. I have no conflicts of interest. So we're going to talk about what neuroendocrine tumors are, how common they are, what tumor grade and differentiation means, what tumor stage means, if you have any symptoms associated with it, are you supposed to have symptoms associated with it, how are neuroendocrine tumors diagnosed, lab markers including serotonin and plasma 5-HIA. We're going to talk about SSTR, which is one of the key players in neuroendocrine tumors. We're going to talk about different imaging modalities, talk about some of the treatment options that we have, clinical trials, and then end with some things that you need to be discussing with your oncologist. So what are neuroendocrine tumors? Neuroendocrine tumors are a spectrum of cancers that originate in neuroendocrine cells. These cells are located in multiple parts of your body, and therefore neuroendocrine tumors can start literally anywhere in your body. The most common sites include gastroenteropancreatic nets, which means the stomach, the small bowel, and the pancreas. But really, any site is possible. Between 1970 and 2012, there has been a 7-fold rise in the incidence of neuroendocrine tumors. And if you have a low-grade neuroendocrine tumor, as Marianne was saying, this is going to be her 25th year, you do live for a long time, right? So there is also a high prevalence given long survival. The United States alone has 170,000 patients living with neuroendocrine tumors. Most cases occur in people over 60 years. But I will say in my own clinic, it's a 50-50 actually. I have 50% of patients who are less than 50 and 50% of patients are more than 50 years old. So NETs are extremely heterogeneous group of cancers. And what I mean by that is it can be related to symptoms, it can be related to your disease course and your treatment. So if one person has grade 1 neuroendocrine tumor and another person has grade 3 neuroendocrine tumor, your treatment, your disease course, your symptoms are not going to look the same. So obviously you want to be talking to your neighbors at your table, but their journey may be completely different from yours depending on your grade and differentiation specific for your type of tumor. One of the first things we want to know when you get diagnosed is the tumor origin. Where did the tumor start? As you can see in the picture, it can start in the stomach. That would be referred to as a gastric net. If it starts in any part of your small bowel, it might be referred to as an intestinal net. If it starts in the pancreas, it'll be referred to as a pancreatic net or P-net. And then if it starts in the lung, it would be referred to as a lung net or a pulmonary net. But like I was saying before, if it doesn't start at any of these locations, you could have it start really anywhere. So moving on to tumor grade and differentiation. So this is determined by a pathology. Anytime you are diagnosed and if you have a biopsy or a surgery, that tissue is sent to the pathologist for analysis, and they look at two different things amongst other things, but the two things that are most important that they look at is the grade and the differentiation. So grade refers to the biological aggressivity of the cancer. Tumor grade is defined by two different things. The first thing is called Ki67, which is a tissue stain. And the second thing is called the mitotic count, which is the number of dividing cells under a microscope. You can have three different grades, grade 1, grade 2, and grade 3. Grade 1 is the slowest growing, grade 3 is the fastest growing. Then we come down to differentiation. Differentiation refers to the extent to which the cancer resembles the non-cancerous counterpart. So the normal tissue around the cancer. How close does it look to normal tissue? If you have a pancreatic neuroendocrine tumor, how much does it look like the normal pancreas? If you have well-differentiated, I like to think of it as well-behaved. If you have poorly differentiated, it's going to behave poorly and be more aggressive. And that would usually be a neuroendocrine carcinoma. So this is just a...
Can it change from well-differentiated to poorly differentiated or vice versa?
So usually, yes, there can be a change in the grade of the neuroendocrine tumor. You may have a grade 1 neuroendocrine tumor, and later on you may have a grade 2 or 3 neuroendocrine tumor. So there can be change, and I'll go into how the grade can change and also what tumor heterogeneity means when we're talking about these things. But it is unlikely that you would have a higher grade or poorly differentiated carcinoma and then you would go back to a grade 1 tumor. Yeah. So yeah, this is just a picture representation. So neuroendocrine neoplasm is an umbrella term that we use under which we have neuroendocrine tumors which are well differentiated and neuroendocrine carcinomas which are poorly differentiated. So as you can see on the picture, for well differentiated neuroendocrine tumors, the architecture of tissue is still maintained, whereas if you look down, all the cells look very haphazard and are actively dividing and looking aggressive. So this is a very simple way of explaining what grades mean, and you guys already probably know this, but grade 1, I like to think of it as a horse cart, slow, and sometimes you can go even without having treatment and progresses very, very slowly. Grade 2 is in the middle category, and grade 3 is usually like a Ferrari. So, we would have to, in most cases, start some treatment because those are not tumors that we can just observe. So poorly differentiated cancers, like I said, are more aggressive. Not all high-grade neuroendocrine tumors are poorly differentiated, but if you have a poorly differentiated cancer, that is going to be high-grade. So this is the classification that we use. I just want you to focus on what's in the block right now. So this is for gastroenteropancreatic NETs. So this is for GI NETs. There is grade 1, grade 2, and grade 3. So under grade 1, your Ki67 is going to be less than 3%, and your mitotic count is going to be less than 2. For grade 2, your Ki67 is going to be 3 to 20%, and the mitotic count is going to be between 2 to 20. And for grade 3, both of those things are going to be more than 20%. For lung carcinoids, the classification is a little bit different. They're divided into typical and atypical. And if you see below, the mitotic count for typical lung carcinoids is less than 2, and for atypical carcinoids is 2 to 10. The other thing that the pathologist looks at when he's analyzing this tissue is the presence of necrosis. So for typical carcinoids, there will not be any necrosis, and necrosis just means cells dying, which is a sign of aggressiveness of the cancer. Atypical, there will be some necrosis present. Okay, and then on the far right, these are the carcinomas. So the mitotic count and the Ki67 is going to be more than 20%, and these are divided into small cell, large cell type, which is really almost always managed the same way, but it's just a histologic or a classification that the pathologist gives us about depending on how the cells are looking under a microscope. So what you were asking before, so this picture is just to show that there can be tumor heterogeneity within cancer. So what this basically means is that, let's say you have a tumor in your pancreas, which is grade 1. You may have a spot in your liver, which is grade 2. Even within a spot or a large lesion in a particular spot, you may have areas that are grade 1 and grade 2. So that's what tumor heterogeneity means when we are talking about pathology. And there is no way to biopsy every single lesion, right? So these are just tools that we are using, and it's a specimen from a specific site within your tumor. So we use it to get an understanding of how the biology of your tumor is going to look like, but sometimes if it's not acting the way we expect it to act, that makes us think differently. Well, this showed us it's grade 1, but it's actually behaving a little bit more aggressive than what I would have expected with a grade 1 neuroendocrine tumor. And then in terms of the grade changing, the tumor heterogeneity can happen anytime, but the grade can change over a period of time as well. Okay, so tumor stage, to put it simply, tumor stage, think of it as how far the cancer has spread. So if you look on the picture on the left, that is a localized tumor. It is located within the pancreas and has not spread anywhere. If you look in the middle, there are lymph nodes involved. Or there may be impingement of structures that are around the tumor. That would be considered a locally advanced tumor. And then if you look on the far right, we have lesions in the liver, which is talking about metastatic disease or stage 4 disease, where it has spread to a distant organ compared to where it started from. Yeah, this is basically just what I said. If the cancer has spread, understanding the extent of spread, it describes how much cancer you have in the body. The staging system can vary amongst different types of neuroendocrine tumors. Of course, in general, the higher stage is going to mean more advanced stage, and then stage 4 refers to cancer spread to distant organs.
So if it's 1 and 2, how do you call it out? Which one is it called out as?
I'm sorry?
If it's like you were talking there, stage 1 and stage 2,
Mm-hmm.
which one is it called out as? Just stage 2? I mean, how do you differentiate that?
Yeah, so it depends on where the tumor started. So every organ system is going to have its own staging system, and we look at the size, how many lymph nodes are involved, is it pressing on any adjacent structures. So to go in detail about every single site is going to be difficult, but that's kind of how those are the basics of differentiating between different stages. Usually, stage 1 and stage 2 in general will not have lymph node involvement. This is just a general overview. It may depend on your particular type of tumor, and stage 3 will have lymph node involvement, and then stage 4 means distant organ involvement.
If you're talking about the grade, if you were asking about if there's a grade 1 and you have grade 2, yeah, so you treat it as the highest one. So we typically will design our treatment around the highest grade, because that's going to be the most aggressive.
And I'm sorry to interrupt real quick. I just want to let everybody know something that I should have said earlier. On your tables are all index cards. Please use those to put your questions in, because these doctors only have 30 minutes or so. So we're going to hold on to all the questions for our Q&A sessions. And this way we can get everybody's questions answered. And don't hesitate to drop it off back there or up front.
Sorry, I misunderstood. You were referring to grade, not stage. Okay. Symptoms of neuroendocrine tumor. So symptoms can vary, as I was saying, between person to person. It depends on the location of the tumor. If you have a mass in your abdomen, for example, which is causing a blockage, you may have belly pain, you may have nausea and vomiting associated with that. If your tumor is pressing on any bile ducts, it may cause jaundice. If you have any blockages in your lungs from a lung neuroendocrine tumor, you may have cough or shortness of breath. And then if the tumor has spread to bones, you may have bone pain associated with it. That is just based on the location and the physical attributes of how it can cause symptoms. The other thing that is unique about neuroendocrine tumors is that there is a subset where you can have secretion of different hormones. So this can be different hormones. The first first one is listed here is carcinoid syndrome. This is when you have an elevation in serotonin, and that is associated with diarrhea, with flushing, wheezing. Those are the most common symptoms associated with carcinoid syndrome. But there are also other secretory syndromes that can happen where you have increase in glucagon or gastrin, insulin, or VIP. These are mostly associated with pancreatic neuroendocrine tumors. And then a small number of lung nets can also produce different types of hormones. Every time I have to change a slide, I'm just standing awkwardly. Please excuse me. So tumor markers, these are not sufficient for diagnosis. These are referring to different labs that are available. The most common test that you may have heard of is chromogranin A or serotonin, plasma 5-HIA. The 5-HIA can be done in plasma or urine. I will say that each neuroendocrine tumor oncologist may have a different set of labs they use. I personally don't use chromogranin often because I don't find it to be helpful. I do check 5-HIAA over serotonin. I find that to be more accurate, and we do have access to checking the plasma, so I prefer doing that over a 24-hour urine test, so you don't have to spend those 24 hours collecting urine. I can understand how inconvenient that is, but it just depends on the availability of what test is available where you are being seen. And then, of course, there are other tests as well, but those are not really standard. Those are available, and it depends from oncologist to oncologist, institution to institution, what their practice patterns are like, but those are not particularly standard tests that are listed there. And then in terms of checking gastrin, like you may be diagnosed with a pancreatic neuroendocrine tumor, and you learn here that, oh, my tumor has the chance of secreting gastrin. It has the chance of secreting insulin. Is my glucose going to drop? But if you did have, if your tumor was actually secreting any of those hormones, you would be telling us that. Most of the times I would say we don't find it after testing. We find it based on your symptoms, and that's when we do the test. Moving on to imaging. So imaging is performed at diagnosis. If you've been diagnosed recently, it's going to be performed right in the beginning to stage your cancer, as we had talked about how staging works, and then for monitoring the disease. So if you have had surgery, then we're going to get scans periodically to catch the cancer if it's going to come back. And of course, if we use imaging to check to response to different types of treatments that are available. There's different types of imaging modalities that are available. So anatomical imaging refers to a CT scan or an MRI scan. PET scans they use radioactive dyes, so it could be FDG18, which is used mainly for higher grade disease. And then most commonly what we use for neuroendocrine tumors is the gallium dotatate PET scan or the copper dotatate PET scan, which is more specific. Sometimes as the tumor grade rises, you lose that SSTR expression, which we'll talk about what that means. And that's why the FDG scan is more helpful. And anytime you have a PET scan, you also have a combined non-contrast, like they don't give you the dye that you would normally get with the regular CT scan or an MRI scan. You would get the radioactive dye for your PET scan, but we're also looking at a non-contrast CT or an MRI along with the PET scan. So this is what I was talking about, what SSTR is, and I think anybody with this diagnosis should understand what this means, because it is a key player in neuroendocrine tumors. So imagine on the right that this is a piece of a small section of your tumor, and on that you have the specific receptor or protein called SSTR. This is important in both diagnosis and treatment, which I'll explain. But imagine that I am actually a tumor, and I'm wearing a red hat, which is the SSTR receptor. Okay. So when you get a dotatate PET scan, that dye is looking for that red hat that the tumor is wearing. It goes and binds to it, and that's why it lights up. So anytime you have this PET scan, that radioactive substance is injected, is the gallium dotatate or the copper dotatate, depending on the institution, what is available. And after the tracer is injected, you wait a period of time, and then you do the PET scan where we see the tumors lighting up. And the same concept applies for a FDG PET scan, but in that case, it's not really binding to a particular receptor. It's just looking at how fast glucose is being metabolized, which is why it's more helpful in higher grade. If you have higher grade or poorly differentiated, they're going to be dividing more rapidly. In a lower grade tumor, FDG PET scan is not going to be helpful at all. In terms of treatment, so everybody's treatment plan is individualized. It is discussed in a multidisciplinary setting. It's a patient-centered approach. So one plan that may work for one person is not going to work for another, right? It's not one recipe that's going to fit everybody. There are, of course, factors to consider, including what symptoms you're having, what is the grade of tumor you have, grade 1, grade 2, or grade 3. Do you have neuroendocrine tumor or do you have neuroendocrine carcinoma? What is the amount of disease that is present? Do we feel safe that we can continue to safely monitor this without any treatment? Have you had any evidence of progression? You had a scan 3 years ago, you've not been on any treatment, but the scan is showing that the tumors are essentially stable. So do we feel like we can continue to safely watch these? So all these factors need to be considered. If you have a grade 3 neuroendocrine tumor or if you have a high grade neuroendocrine carcinoma, your oncologist is not going to recommend just watching that. The goals of treatment need to be established as well. When you present and you only have one lesion in your liver and you have a small bowel neuroendocrine tumor, you have surgery, right? So all the visible disease has been taken out. So you don't need further treatment. So what is the goal? Are we trying to get everything out and cure you? Or are we dealing with multiple spots in your body where we're going to be on a lifelong journey with hopefully some breaks, but with different types of treatments? And then one important thing we always discuss in our neuroendocrine tumor board with Dr. Rose is that can we surgically debulk, right? So is there, even if you have multiple spots in the liver, I always discuss, is this something that we can debulk? And by debulking, it doesn't mean that we have to take out everything, but are we able to take out more than 70% of the disease that is present? Because that can also help you live longer. And the timing of starting somatostatin analogs. I see some faces in the audience where we've had discussions about, do I need this injection? Can I come off this injection? How long to continue it for, right? So it's not everybody has to stay on an injection for the rest of their life, especially if they have a low-grade tumor. It's been diagnosed and it's been stable without any treatment. So again, this is the same receptor. I just want to explain how those injections that some of you may have been on, how those work. So we were talking about the PET scan, how the dye binds to that red hat and lights up on the PET scan. It's the same concept, but in this situation, when you get that injection, that drug binds to this receptor and it's sending signals inside the cells and decreasing cell proliferation. It's decreasing your symptoms associated with carcinoid syndrome and controlling hormone secretions. So the two common somatostatin analogs we have are octreotide and lanreotide. You may or may not have been on one of them. And you're going to hear more about PRRT later on. But again, we are using the same receptor. Now it's through Lutathera or lutetium dotatate, we are actually delivering radiation to the cells. And that's basically how Lutathera works. But SSTR is a key player because it's being used for diagnosis with a PET scan, it's being used with the somatostatin analogs such as lanreotide, octreotide, and it is the same receptor we use for Lutathera. So just few points about treatment, how to sequence treatment. Do we need to start SSA? I've kind of talked about that already. What are our options? I think anytime we meet in clinic, it's important to discuss, is it the right time to start treatment? What are the options that I have? Do I need chemotherapy? Is there anything local that can be done? How do you choose between PRRT and any type of chemotherapy agent, for example? So that is a discussion between you and your oncologist and what is going to be right in your case. And I often see meet people in clinic, and we talk about, okay, I have 2 spots and they have been stable. But why can't we just do treatment to take care of it? It's because we have options, we have several options, but our options are finite, right? So we want to give you the longest survival, and we want to use the options wisely. And again, this may be different for somebody who has low grade versus high grade, right? High grade, we're going to be starting treatment quickly, and whereas for low grade, you can continue to observe for a long time. I know we're going to talk about clinical trials later too, but just some of the clinical trial myths that I want to start the discussion about. Not all clinical trials are interventional. Some of the trials may just be looking at different tests that are available, procedures. So it's important to understand what clinical trial is available, and if it is, first of all, is it an interventional study or not? The second thing to understand is that not all clinical trials are going to have a placebo. So anytime you're being considered for a clinical trial, talk to your oncologist about, does this have a placebo arm, or am I going to get one treatment versus another? Clinical trials are not only for seriously ill patients or the last resort. It depends on what the clinical trial is testing, what line of treatment it is testing. So if you are interested in participating in a clinical trial, you want access to something state-of-the-art that is being worked on, you can talk to your oncologist about that. And if I don't have a trial at UAB for something particularly you're looking for, if your oncologist at another place doesn't have a trial, we obviously will get you connected to that person who's running a clinical trial at that other institution. So some take-home messages. Neuroendocrine neoplasms, they can arise in almost any part of your body. They're heterogeneous in terms of symptoms, disease scores, how your treatment is going to look like. If you've been recently diagnosed, know your pathology. So know your grade, your differentiation, your stage, where did the tumor start, and what are the goals of your treatment. And do not think of these tumors as other types of cancers. They're very unique and treated very differently. So a pancreatic neuroendocrine tumor is not the same as pancreatic adenocarcinoma, right? So we often get that in clinic, and the treatment options are going to look completely different. If you don't have any symptoms associated with it, that's good. Okay, so because most people actually do have non-functional tumors, okay? Carcinoid syndrome can definitely, carry a burden, and you have to, be on the injections and maybe other medications to control your symptoms. So it is obviously okay to not have a functional tumor. It doesn't mean anything. And in general, obviously, your tumor is going to require a multidisciplinary approach. Each patient's case should be discussed in a multidisciplinary setting with a radiologist, with a surgeon, interventional radiologist. There are multiple players who are nuclear medicine for PRRT, multiple players who are helping devise a plan for you. This is just the summary. 5 things to discuss. Where did my tumor start? What is the grade? Is my tumor functional? Do I need treatment at this time, or is monitoring an option? What are my treatment options? And then if you have not met a NET specialist in the country, seeking out to meet somebody, even if you're getting care locally, I would advise doing that. And that's all I have for today. This is my contact information. Feel free to reach out to me. And I think Dr. Rose is going to be the next speaker. Thank you.